Hump Day with Dr. Alex Earl. And of course, it's the time I get to spend with you guys, and of course, teach you all about plastic surgery, okay? You know that it's coming from a good and reliable source because I'm a double board certified plastic surgeon, all right? So today, what are we going to talk about? So today we're going to talk about a topic that came up recently, and I'm going to go through that in great detail. And then of course, after we're done with that, I'll be happy to answer your questions regarding anything in plastic surgery, really from head to toe. Okay, but today we're going to be talking about wound dehiscence, okay? And you might be wondering, Dr. Earl, what does that mean? All right, we're going to get into that here in a bit, but yeah, this subject came up recently as a couple of surgery bloggers out there try to create, some drama with a patient of mine that had a wound dehiscence. Based on that and based on a lot of the comments, it dawned on me that unfortunately, there's really quite a bit of a lack of knowledge when it comes to this, okay? Most people, when they see a wound, they don't really know what it is, and so you had some like crazy outlandish comments like, oh my god, it's flesh-eating bacteria, oh my god, her arm is going to fall off, she needs to go to the ER, and all these things. And what that just tells me is that a lot of people don't know about wounds and how and what can happen and how to treat them. A lot of people don't even know that the ultimate wound care doctors are plastic surgeons. Okay, so we're going to get into all this because there's a lack of knowledge out there, and rather than create drama, I think it's a great opportunity to actually educate you all and educate our patients. Okay, all right. So dehiscence. Dehiscence is a fancy word. What it means is wound separation. Okay, and when we're talking about wound dehiscence, we're talking about basically the opening up of a surgical wound. Okay, so you did a surgical wound for whatever, an arm lift, a thigh lift, and part of it or all of it opened up. Okay, but of course that doesn't only pertain to plastic surgery. It can be any surgical wound. Actually, the ones that tend to separate out the most, today I'm going to focus on plastic surgery, but the ones that tend to separate out the most are from what we call laparotomies, right? So what is a laparotomy? That's when you open up the belly from here to here, all the way, right? When you have like big surgery, like big traumas, or big, like colon cancer and stuff like that. So those tend to, open up and have a wound dehiscence, and potentially those can be a lot more dangerous than what we're going to be talking about now, because if that wound dehisces completely, your guts can come out, and that is a true emergency. But we're not talking about that here. This is plastic surgery, okay? So in plastic surgery, we rarely have vital structures underneath the wound, right? We deal more with the skin and the subcutaneous tissues. We don't get into the viscera. We don't get into where the organs are and the large blood vessels and all that, okay? So it's a lot less, it's not as complex as some of those other wounds, okay? So what are the different types of wound dehiscence? Well, of course, you have your partial wound dehiscence, meaning that a part of the wound opened up, and your total wound dehiscence, meaning the entire thing just opened up. A total wound dehiscence would be pretty rare. That almost never happens. So typically it's a partial wound dehiscence. And then of course it can be a simple wound dehiscence, or it can be complex. Simple just means it simply just opened up. It needs to be treated with what I'm going to talk to you about now, and eventually it'll close on its own. Complex means that there's something else on top of that separation, like for example, an infection, okay, or other issues, like maybe there was radiation prior to the area. So that's what will make it complex. Most of the ones that we deal with here, especially at Pure Plastic Surgery, since we typically deal with young, healthy patients, are simple partial wound dehiscence. Okay. All right. And who can it happen to? It can happen to anyone. It can happen to anyone. The only way that a surgeon is going to have a 0% wound dehiscence rate if he doesn't do surgery. Okay? It's like I've always said, the only way that any surgeon can have a 0% complication rate is because they're not doing surgery. Okay? If you do surgery, and if you do quite a bit of it, like we do, 1,200 cases a year, okay, there's going to be a certain complication rate, but of course ours is very, very low, much lower than national average. Okay? All right, so what are the surgeries where this happens? So the number one surgery within the world of plastic surgery where this happens is the thigh lift. Thigh lift, okay? So that's why whenever I have a patient that does come in for a thigh lift, I talk to them a lot about wound dehiscence. I don't talk about it so much with the other ones. But with the thigh lift, you definitely have to talk about that because it can happen about almost, sometimes close to about 50% of the time, but quite high, okay? Why is that? Well, because you gotta walk, you gotta move around, right? So you can't isolate the area, and especially the upper part of the thigh lift is very near the groin. The groin, of course, is not a completely clean area at all times. And there's typically some moisture there, right? There's sweat and moisture and things like that. So in the groin, so when you do your thigh lift in that area towards the groin, it's definitely it can definitely open up. Okay, so thigh lift is number one. And then arm lift is number two for very similar reasons. Again, you got to use your arms, you got to move around, so you can't isolate the area and not move, okay? And your part of the incision, or depending on the type of arm lift that you do, is going to be inside the armpit. Once again, a high moisture area, a lot of sweat glands there, okay? Moisture goes against wound healing, okay? And of course, tension and movement goes against wound healing as well, all right? So these are the ones where it's the most common. This one we've talked about a lot. I'm sure you guys have heard me talk about this, and of course I've done a few kind of lives on this, and I've done some educational posts in our Facebook group on that as well. So in terms of the breast lift, is when we do that anchor type pattern. There's a spot towards the bottom of the pattern. So if I could draw the pattern here like this, you see the pattern, it looks like an anchor, and then in this spot right here, where that vertical and horizontal scar meet, that can open up. And that's not unusual. I would say maybe about 20% of the time, okay? So not too unusual. Right in that spot, it's usually not a big deal. It's definitely what we call a small partial simple wound dehiscence, and it's typically about 1 centimeter or so, not more than that. And once again, the treatment is fairly straightforward, just a little antibiotic ointment, a little dressing changes, and it heals on its own, okay? So that's an important one to know if you're going to be having that anchor type pattern breast lift, okay? And then the last one is our tummy tuck, okay? Tummy tuck, if it's going to happen, where would it happen? It's usually in the central lower incision there. That's the point of the most tension. You're always going to have the most tension centrally and low, okay? So sometimes that can open up a little bit, and plus minus, you can have a stitch that wants to spit out, or sometimes you can have potentially a little infection in that area where you actually want to open it up to let the infection out, okay? But tummy tuck, I would say definitely number 4, not as high as the ones that we have here, okay? So thigh lift for sure, number 1, number 2, arm lift, then the triple points of the breast lift, which is typically not a big deal, and then your tummy tuck, especially if for some reason there's an infection. Now let's see, pop quiz here, because you guys have heard me talk about it before. What's the number 1 reason for infection after a tummy tuck? Ta-da-da! Who's heard me talk about this?
Wait. I'm waiting. They have a little delay.
Yeah. Dirty belly buttons. Dirty belly buttons. That's the number 1 reason for an infection after a tummy tuck. Everybody, guys, please clean your belly buttons before surgery. You should clean them all the time.
Jackie Brassa says hygiene, of course.
Yes, hygiene, that's right.
Hygiene.
You should always clean your belly button, but especially before surgery, make sure you get in there, okay? I can't even tell you the amount of stuff that we found in belly buttons. But we found all sorts of crud and rocks and nastiness there. So guys, you should clean your belly button every day, but definitely before surgery, make sure you get in there, use a Q-tip if you need to, clean all that out, make sure you have a clean belly button before your tummy tuck. Very important to prevent infection, okay?
With alcohol or, I don't know.
With alcohol? You can use alcohol or you can use hydrogen peroxide, that works as well. And like I said, a Q-tip, you can dip the Q-tip inside the alcohol or the hydrogen peroxide, get it all the way in there, make sure you clean everything out. Some people's belly buttons can be fairly deep, okay? And so you want to make sure you get all the way in and clean all that out, all right? All right, perfect. Okay, so now we know what it means, we know the different types there are, we know what surgeries are the most common to have this, okay? And so now, actually I'm gonna skip treatments for now. I'm gonna talk about the risk factors, okay? So what are the risk factors, okay? So the first one I kind of mentioned a little bit already, which is tension. Tension on the wound, right? So if you're stitching something together and it's constantly, being tried to be pulled apart, that's going to lead eventually to a wound dehiscence, okay? And so unfortunately though, there's certain areas of the body which you can't immobilize after surgery. So that's why that thigh is number one, because we don't want to immobilize you, because then we run into other issues, bigger issues, which are blood clots, right? So walking after surgery is extremely important. So you have to walk, because we want to prevent blood clots, which those can lead to major issues like a pulmonary embolus and death, okay? So you have to walk, and because of that, there's going to be more tension on those wounds, and because of that, the wound dehiscence rate is higher, all right? But, of course, you don't want to overdo things. So one of the things we always say is that for any of these surgeries, for the first 6 weeks, there can be no heavy lifting and no strenuous activity. So no heavy lifting, all right, no more than 10 pounds, and no strenuous activity, so definitely no gym, no running, jumping, jogging, anything like that, okay? And for those, patients that perhaps don't have a lot of help in the house, you gotta plan this out, right? Okay, so, if you have small children, pets, anything that needs to be taken care of, you got to think about this ahead of time, okay? You can't go home and then, think that you can kind of take care of the household in the way that you normally do after surgery like this, because then you're going to be putting more tension on your wound, okay? And then that's going to cause that wound to split open, okay? And a split open wound, by definition, that's it, wound dehiscence right there, okay? So that's the one factor that the patients can control, okay? Another one that the patient can control is smoking. Definitely no smoking. Smoking is bad. All right, so if you come here for surgery and we do your nicotine test and it's positive, we cancel you. You won't even do the surgery because smoking poses such a high risk for wound dehiscence. And those are some of the times when you see a total wound dehiscence, when the whole thing just opens up, okay? Why? Smoking has nicotine. Nicotine constricts blood vessels. That means less blood flow. That means all the nutrients that are needed to heal that wound are not getting to that wound, okay? And therefore the wound can't heal and it opens up. So if you're a smoker, nobody should be a smoker just baseline, but if you are a smoker, you gotta stop that at least 30 days before surgery to 30 days after surgery, okay? To allow that wound to heal. And if you come to surgery day and your nicotine is positive, surgery will be canceled, okay? So that's something else that the patient can control. All right, diabetes, of course, you can't really control whether you get diabetes or not, but if you do have diabetes, you have to make sure that your sugar levels are stable, okay, and within range. If you have uncontrolled diabetes where you're either spiking a lot or your sugar levels are consistently high, that's going to lead to wound issues, all right? So whether it's type 1 or type 2 diabetes. All right, so you want to make sure that your diabetes is stable, and that's why we check all our patients with a special lab that's called the hemoglobin A1C. Hemoglobin A1C, okay? And we got to make sure that one is 6.5 or less, okay? And that tells us that your diabetes is under control. If it's above that, then typically your diabetes is not under control, and then you shouldn't be having surgery because your risk of wound dehiscence plus other risks such as infection and basically what we call tissue dying or tissue necrosis go up higher as well, okay? So diabetes, make sure that's controlled. The next one is immunosuppression. So if you're in immunosuppression for whatever reason, whether say it's ulcerative colitis, Crohn's disease, cancer, etc., you should not be having elective surgery, okay? If you're immunosuppressed, that means that you're suppressing cells, for a reason, say because of cancer, but that immunosuppression also suppresses the cells that you need to heal, okay? So if those cells are being suppressed, then you can't heal correctly and wounds open up, all right? All right. This one is also very important, especially for our weight loss patients, which is poor nutrition. So a lot of times when you undergo bariatric surgery, especially, with your gastric bypass, sometimes you can't absorb the nutrients as well after a gastric bypass or bariatric surgery. And so even though your weight might seem normal, your nutritional status is not, okay? So you want to optimize your nutritional status before getting surgery with important factors, like iron and zinc. Those are all very important to make sure that they're at the adequate levels before surgery to minimize risk of wounds that are not healing, okay? So we see that more with our massive weight loss patients, especially those that underwent bariatric surgery or those that lost weight like really, really fast, okay? Because obviously in order to lose weight, you're not taking in as many calories, perhaps you're not taking in as much vitamins as you need, and your nutritional status can be poor. So typically, before we do a surgery, say as a mommy makeover or a brachioplasty in these massive weight loss patients, we typically ask them to be at a stable weight for at least about 4 to 6 months, because that way we know that usually their nutritional status is going to be better. And also, we always have to get them cleared by the primary care doctor, who should also be keeping an eye on their nutritional status as well. All right. For nutrition, we talked about immunosuppression. Radiation, we don't see that a lot here now at Pure, but when I was at Cleveland Clinic, Florida, and I did a lot of breast reconstruction, we would see that because part of the treatment for breast cancer can be radiation. Radiation permanently alters the tissue that gets radiated, and that tissue notoriously has a much harder time to heal. All right, so if you had an area where it's been radiated and you create a wound there and try to put it together, the chance of a wound dehiscence is much, much higher. The next one is autoimmune diseases. This is something that unfortunately the patient can't control. But that's why we don't do patients with autoimmune diseases for elective surgery here at Pure. All right, so autoimmune diseases basically means that your body attacks certain cells, and part of those cells tend to be the ones that are needed for healing. Okay, so typically people with autoimmune disease, at least here at Pure, are not a candidate for elective surgery. All right, and then the last one, another one that you cannot control, is genetics. So some people just heal better than others. But also there are certain diseases, genetic disorders, let me put it that way, where there is poor healing, like Ehlers-Danlos and other disorders like that, which actually physically affect the tissues and how they heal. And so there are certain genetic disorders that will lead to poor wound healing and much, much tougher times trying to heal the wounds. All right. In terms of autoimmune, the most common one that we get is lupus. So unfortunately, I know there's a lot of patients with lupus out there, and they would love to get some of the surgery, but the reason that we don't take patients with lupus is because it's a lot tougher for them to heal, and we wouldn't want them to have, unfortunately, like a total wound dehiscence or something like that, which would be a very, very tough recovery. Okay. All right. So these are the risk factors. So as a patient, definitely post-op, you want to avoid tension. And remember, absolutely no smoking or being around people that smoke. All right? All right, so now, unfortunately, so you've had the surgery, you've tried to do everything that you could, but unfortunately now you've had a wound dehiscence, okay? Well, the good news is that the most common type of wound dehiscence after surgery, and the type that this patient had, is what we call the partial simple wound dehiscence. And honestly, even though it may look a bit alarming, I guess, to people that don't see wounds all the time, the treatment for a partial simple wound dehiscence is pretty straightforward. And though it may take, sometimes anywhere between 2 to 6 weeks for it to heal, eventually things will heal up, the wound will close, everything will contract, and then we'll see how the scar looks, and then you may or may not need a scar revision, which can be done simply under local anesthetic after everything's all healed up. Okay, so what's the number one treatment? A lot of times it's just a little bit of ointment, and what do I mean by that? Antibiotic ointment. So the common ones that we use here are mupirocin and Silvadene. And so you may ask, well, Dr. Earl, it's a simple wound, and why are you using an antibiotic ointment if it's not infected? And that's a great question. So why do we use that if it's not infected? Well, it's to prevent an infection, right? Is to prevent an infection. So you don't want it to get infected. So that's why we use the ointment there. And then the other question that we get all the time is, Dr. Earl, why don't you just close the wound? All right, why don't you just close the wound? It was closed, it opened up, now go back and close it, right? So that's a great question, and it's the one that I think confuses the people the most. Once you have a wound that's opened up and it's been exposed to the elements, so I'm not talking about a wound that opened up inside the sterile environment of the OR. We're talking about a wound that opens up anywhere else, at the house, in the park, etc. Once that wound opens up, okay, and especially if it's been 2-3 days after surgery, there's first of all, it's full of inflammation, okay, and it's all swollen up, and then there's bacteria everywhere. There's bacteria on this counter, there's bacteria on my skin, there's bacteria on my nose, and pretty much everywhere, okay? So once a wound opens up and it's exposed, and you then go and close it, you're essentially just sealing all that bacteria inside, and bacteria love a closed, warm little space. They just love it. They eat it up, and they multiply like crazy, and then you're going to have an infection, and then you're going to go from a simple to a complex wound, and that's going to be a problem, okay? So you don't want to do that. Actually, that's the last thing you want to do. It's the last thing you want to do, okay? So first you're going to treat it with the ointments, and then once the wound starts to kind of mature a little bit, then you can go into what's called a moist to dry dressing change. Moist to dry dressing change is something that we've been doing for ages, okay, before we had fancy stuff. And what it is, quite simply, you get a 4x4 gauze, you put it in some normal saline, you squeeze out the excess, you don't want it sloppy wet, you just want it moist, okay? You squeeze out the excess, you put that moist part inside the wound, okay? You don't want it on the normal skin, all right, because then that skin's gonna get macerated. So you put it in the wound, and then over top of that, you cover it with a dry gauze, and then you just hold it in place with either your garment or tape or whatever, okay? And you change that either once or twice a day, and that's it. Very simple, very straightforward. That's why I like it, because you can get all the materials at any Walgreens, any CVS, and pretty much anyone can do this. Anyone can do this, okay? So it's very simple, very straightforward. What's the downside? It's gonna take a while. It's gonna take 3 to 6 weeks, easily, okay? So it takes a while, but eventually that wound will close, it will not get infected, okay? And everything will seal up. And a wound that looks like this big, after everything closes, it can end up being like very small, okay? Why? Because your body has incredible power of contraction. Wounds always, always, always contract, okay? There's actually these special cells that we have that physically do that. They bring wounds together. So wounds that at the beginning may appear very, very large, or at least, that you're not comfortable with, eventually when they're closed, they're going to be much, much smaller, okay? So the moisture dry dressing changes helps with that. Now there are fancy things, right? There are, of course, wound care centers, which kind of dedicate themselves to doing this, and they're going to have all sorts of fancy tissue matrices and powders and things like that, and they may be able to close these wounds a little bit faster. They're typically very, very expensive, and of course you're going to want to do this with your insurance, because out of pocket it's going to be prohibitively expensive, okay? But there are some fan things in there, and they're made of all sorts of weird stuff. You can get them from pig. Some of these matrices come from pig, and all sorts of things, okay? But there's even one, believe it or not, and you're going to think I'm crazy. There's even one that comes from baby foreskin. Believe it or not. It's kind of weird, but it's true. All right. So you have tissue matrices, okay? Again, they can be effective, but they can get expensive, and typically you need someone like a wound care nurse to apply these. So that's why the moisture dry is the easiest. Anyone can do this, very easy to do, very straightforward, okay? Now, if you have a larger wound, a little bit of a bigger wound or a deeper wound, then you're probably going to want to use what's called the wound vac. All right, the wound vac is actually the sponge that kind of fits in the wound, and you do put it on suction, and then that allows the wound to heal and contract quite quickly, actually. So that's why it's great for larger wounds. Typically, you can go sometimes through insurance for this as well, and for that, a lot of times you're going to need a nurse, like a wound care nurse, to come over and apply it. and you typically change this either 2 or 3 times a week, depending on the wound. Okay, but you do have to walk around with a little machine that provides the suction. So you have like this purse kind of looking device on you at all times while that wound vac is working. All right. Next, for a little bit more complex wounds, say wounds that have either been radiated or there's some, they had infection at some point or they have poor blood supply, then hyperbaric oxygen can help. Okay, so you can go into a hyperbaric oxygen chamber, and that's going to help bring more oxygen to the area, more nutrients to the area, and allow the wound to heal a little bit faster. Okay, now everything that I've mentioned so far can be done typically by a wound care nurse or a wound doctor that's not necessarily a plastic surgeon. Okay. Here's another thing that came up. People were saying, get to wound care, plastic surgeons, they don't know what they're doing, right? That's absolutely wrong. The ultimate wound care doctors are plastic surgeons, okay? This is part of our training when we do our residency, and it's a big part of what we do when we do reconstructive surgery, right? So a plastic surgeon is not just a cosmetic surgeon, right? It's plastics and reconstructive surgery. That's of course what I am. That's where I've been trained, and then I worked at Cleveland Clinic for 5 years as a reconstructive plastic surgeon, all right, working on reconstruction and wounds, and so we get a lot of training in this department. And what I'll tell you is that at Cleveland Clinic, for example, we did have a wound care nurse, and she would take care of a lot of things, but when it got more complex for her, she calls me. She calls the plastic surgeon, right? The ultimate wound care doctors. And why is that? Because everything that I mentioned so far, right, ointment, moist to dry, matrices, wound vac, all that can be done by a wound care nurse, okay, or a physician who's a non-specialized plastic surgeon. But once the wound gets really complex, then you definitely need a plastic surgeon, because we are the ones that do what's called complex closures and flaps. Flaps is when you take tissue from one area to another, okay, to cover a wound. Now these are very complex surgeries, and I can't get into like all that here today, but that is basically where we come in when you have a very difficult wound. We can do a complex closure, a flap, or something called a free flap, which is the most extreme, and I used to do these at Cleveland Clinic, Florida as well. And that's basically when you take healthy tissue from one part of the body and you transplant it to another part of the body, and you hook up the arteries and the veins with the use of a microscope. All right, so very complex surgery. I did this a lot for breast reconstruction. So you take an area of the breast that's been radiated, okay? You can't just put in an implant there. You can't put in a tissue expander. You have to bring in healthy tissue. So we would do basically almost like a tummy tuck, but we keep the artery and vein connected, and then we transplant that to the chest. We basically build the breast with it, and we reconnect the artery and vein with the use of a microscope. It's called microsurgery, okay? So free flaps. That's the ultimate wound reconstruction there. All right? And this all falls under the purview, the guidance of plastic surgeons, okay? All right. So I've talked a lot. So I'm happy to answer any questions regarding this. Or any plastic surgery topic that comes to mind.
It's fine if I told you just in order, because
okay, we can go for it.
Well, the first one, do you do abdominal edging?
Do I do abdominal etching? Yes, we certainly do. We do abdominal etching and HD lipo, or high definition lipo, as well. And so that's available, for the right candidate. Of course, you have to have certain BMI. And you have a certain skin quality, right? So the skin has to be fairly tight for that to work. And the other thing I want to say about abdominal etching HD is that it takes a great commitment from the patient post-op in terms of their nutrition and their exercise once they're able to exercise, because you have to maintain that abdominal etching.
Okay, the next one. For round 2 BBL, for round 2 BBL, with the tummy tuck, can you sit, or how do you recover?
Right, so I typically don't combine a BBL and tummy tuck at the same time, okay? The reason is because the recovery is so tough. So for the tummy tuck, you're supposed to be, laying face up, and sometimes in a kind of inclined or reclined position. And of course, for your BBL, you don't want to be putting any pressure on the buttock or hips, okay? The other thing that we have here in Florida, in addition to that, is that we're limited to removing only 1,000 cc's of fat when we combine a tummy tuck with a BBL, and that's not going to be enough to really create a big difference in terms of the liposuction or the buttock and hips with the only 1,000 cc's to transfer. So it's best to separate out those two procedures, okay?
Okay, the next one says, what is a skinny BBL and how do you know if you should get one?
So a skinny BBL means a few things. So typically it is on a lower BMI patient, okay? So BMI, say anywhere from 21 to maybe about 24 or so. And also the look that the patient is going for is more of a look that's enhancing their natural foundation, okay? So in short, kind of an enhanced natural look to that patient. But they're not looking to go for like a super drastic change. So those are kind of things that play into the skinny BBL. And if you combine that with minimal incisions and very well hidden incisions, well then that's what we call our South Beach butt lift, which you can only get here at Pure.
Okay, doctor, how many surgeries do you do per day?
So the max number of surgeries total that I would do per day is 5. I limit myself to 5. But in terms of BBL, the max that I do in a day is 3. Okay, I was kind of doing that already, but right now it's actually mandated by the Florida Department of Health. So under that new emergency rule, so we can't do more than 3 BBLs in a day. So if I have 3 BBLs, then the other 2 may be like a mommy makeover, a breast lift, breast lift implants, tummy tuck, etc. Any other of the body contouring surgeries that we do here.
Yeah, this is a good one. She asked, what's a good hemo level to get a BBL or a lipo or any procedure?
So pretty, what I would call a good level would be 12 and above, okay? 12 and above is a pretty solid level for your hemo, okay, for lipo 316 BBL. We do accept from 11 and above, but if you're going, if you're between 11 and 12, we're definitely going to be using that cell saver, okay, and it becomes really important. And we try for all our patients to try to get 12 or above, and so that's why before surgery, we're going to give you some vitamin C, some folic acid, and some iron supplements to get you to that level.
Okay, we have a lot of people here. We're going up and up. This is really nice. And how do you calm a patient down who has anxiety when getting put to sleep?
Yeah, so that's a great question. So part of what we try to do here at Pure is to make sure that the anxiety levels are down, that the patients feel comfortable being here, of course, with myself and with the staff. And so a lot of that work actually comes in before the patient shows up, okay? So these educational topics that we talk about, really the main goal for all the social media is so the patients get to know me and they get to know our staff and they get to know about their surgeries and what to expect. And so if you're informed and there's great communication, that by itself is going to bring down anxiety levels. And that's a lot of what we do here at Pure. Now, once you get here, and you still have some level of anxiety, and say you are already prescribed something for anxiety, like a Xanax or something like that, then it's okay for you to take that. Now, if you're not prescribed, I'm not gonna do a new prescription for you, okay? But I think just the way that we talk to the patients, the way that my staff communicates to the patients, the setting that we're in, we create a very calm and nurturing environment. And that helps the patients a lot in terms of how they feel before going into surgery.
Okay, this is another one. And can you talk a little bit about the BMI and what's your maximum BMI and what does it mean?
Yeah, so BMI stands for body mass index. It's basically a formula that takes in, it has to do with your height and your weight, okay? The max BMI for me is 30. All right, and then for certain procedures, you do have also a minimum BMI. For example, the BBL minimum BMI is going to be somewhere around 21. What does that mean? Well, as you start getting up and up in BMI, okay, your risk factors start to go up. Okay, one of them being wound dehiscence, and then others ones being blood clots, okay, DVTs and PEs, and infection. So, and then of course respiratory issues after surgery as well. So the higher the BMI, the higher the complication rate. And so you want to try to minimize complications as much as you can. The other thing is in terms of your long-term results. So if you're able to get your BMI lower and stable, then the result, you're going to enjoy your results after surgery for a much longer period of time.
Okay, another good one. How long after pregnancy is it safe to get a BBL?
So you want to wait at least 6 months. Okay, you have to give that body enough time to basically recover from the pregnancy, and you're going to need at least 6 months for your body to do so. All right, if you can wait a little longer, perhaps even better, but certainly no less than that.
Okay, doctor, this just came up. And can you get a BBL if you have fibroids or fibrosis,
Yeah.
I mean, on the uterus?
Yeah, fibroids. Yeah.
Fibroids. Okay.
That's right. So, yeah, you can. You certainly can. And if they're like small to medium fibroids, it really doesn't impact us at all. Now, if you have a very, very large fibroid that's kind of like pushing and kind of protruding a little bit, you can do the surgery because we're all superficial to that. However, you're probably not going to enjoy your results as much because you're still going to be able to see that fibroid. So if you have a fairly large fibroid, then you may want to take care of that first before then doing your lipo360 or BBL.
Downtime you recommend for a mommy makeover. She wrote a moment makeover, but it's a
Mommy
moment.
makeover? Yeah. So it's going to be 6 weeks in terms of no heavy lifting, right? Remember, no tension, right? No heavy lifting, no strenuous activity for 6 weeks. You don't want to lift more than 10 pounds during that time. Now, in terms of, say, driving, most people are perhaps driving around 4 weeks after a mommy makeover, and that's also around the time you could probably go back to an office-type job, in terms of that type of setting.
Okay, Doc, this is a really good one. Which should I get first? Breast reduction or SOBI butt lift? So BBL.
Yeah. Those you can choose, really. I mean, you certainly can't do them at the same time. But in terms of the breast or the SO BBL, whichever one you want to take care of first, that's okay. And then how long you have to wait in between? Good time to wait would be about 3 to 4 months.
Can we take 2 more? We have a lot of people right now.
Yeah. All right.
Doc, okay. How do you feel about performing BBL reductions? You do that?
That's a good question and a subject that's coming up more and more now. So, as we all know, trends change, right? And so at the beginning, or I don't know, several years ago, there was a big trend for what people call like a vixen look, very, very large hips, very, very large buttock. Okay, and now that trend's starting to shift a little bit. And so people are not asking for that so much anymore. But what's happening though is that we're getting more and more patients that are looking now for a reduction in the hips and a reduction in the buttock, and then basically a changing of their shape once again to something that fits their frame a little bit more. And so we certainly do that, but it is on a case-by-case basis. So you have to throw that little caveat out there. But if I look at your photos and I think it's something that we can achieve, then certainly, then of course we will move forward and do that for you.
Okay, I keep this question as the last one because for me it's a really good one and has to do with hemophilia. Have you ever worked on someone who is carrier for hemophilia, and if it's possible to get a procedure having hemophilia?
Yeah, unfortunately, no. So if you have any blood disorders such as hemophilia, von Willebrand's, sickle cell disease, things like that, bad thalassemias, a lot of those blood disorders we're not able to do the surgery, right? So remember, what we're doing here is completely elective, office-based, aesthetic surgery. Okay, so we want to make sure that we're not going to run into any big complications. Hemophilia can lead to excess bleeding that we can't control. So we don't have like all the factors and everything that you would have in a major hospital here, like factor 8, which is what most hemophiliacs need. We don't have that available here. So no, we wouldn't put ourselves in that position where it could be potentially a danger to your life. So unfortunately, no hemophilia, no von Willebrand's or other kind of blood diseases or disorders.
Okay, well, that's it.
All right.
Remember, it's gonna be on YouTube.
Yeah. All right, everybody. Awesome. So yeah. So today we were live on YouTube as well. And so if you missed some or part of this, you can certainly go to our YouTube channel. You go to Pure Plastic Surgery on YouTube, and you can catch this live here today, as well as multiple other lives, which pretty much will answer any question you can come up with regarding plastic surgery. We've been doing this for about 4 years now. So pretty much anything that you can think of regarding plastic surgery, there'll be an answer for you there. All right, everybody. So I look forward to seeing everyone next week on Hump Day with Dr. Alex Earl. Take care.
Ciao.